This is Healthcare for All Washington's second Wednesday speaker series. We meet on each month with several different topics. I am Ronnie Shure, and I'm a volunteer. I volunteer as president of this board of directors for Healthcare for All. Tonight, we're going to be following up on a panel discussion that led off our annual conference a couple of months ago. It was a discussion that looked at several ways of lowering drug prices. It featured Senator Kaiser, a Washington State Senator who is a true healthcare champion, Dana Brown from a national group called the Democracy Collaborative, which has been very involved in public manufacturing as a way to help lower prescription drug prices, and Gabriel Levitt, who is with another national organization that was called Prescription Justice. And he's been working on national as well as international aspects of ways to lower drug prices. And I urge you to go to our website, HCFA-WA, Healthcare for All Washington.org, and you can see under events that our previous YouTube videos of our second Wednesday speaker series. Tonight, we're going to focus on a more specific aspect of lowering drug prices, which is what we can do about a hidden aspect of the pharmacy billing and purchasing mechanism in our healthcare system. Please consider joining us, volunteering with us. If you look in the chat, we will be sharing our link for our website. You can go there and make a donation. We are hoping to get your donation if you're able tonight. There'll be a donate button on our website, as well as a place to get involved, a button to do that, to volunteer for our policy committee, to volunteer for our communications committee or our outreach, our fundraising outreach committee. We'd love to have you get involved. Tonight, we've set a goal of $500 to raise $500 during the program. I don't want to sound like a public radio fundraiser, but that's what makes this organization work, gives our volunteers the ability to do the work that we're doing. It allows us to maintain our website with our communication specialists and get involved in legislation with our lobbyists. So please, if you are able, make a donation tonight. One of our volunteers, Cello Echeverria, will be tracking any questions. So if you have questions, just enter them in the chat. After the presentation or discussion, we will be looking at those questions in chat. So throw them in at any point during the program. Also notice that you can click the closed caption icon at the bottom of your Zoom screen, down there. And that will enable you to see a closed captioning readout of what we're saying. I am participating in this Zoom meeting today from the lands of the Coast Salish people. Please take a minute to acknowledge the peoples and the lands where you are joining us from today. We acknowledge all the ancestral homelands and traditional territories of indigenous peoples who have been here since time immemorial. Our efforts to achieve healthcare for all includes universal healthcare coverage for the Coast Salish peoples of this land, the land which touches the shared waters of all tribes and bands within the Duwamish, Muckleshoot, Puyallup, Suquamish, and Tulalip nations. So thank you for joining us in this effort to transform our healthcare system. I have muted everyone, and now I'm going to ask our participants to join us. So why don't we start with Jenny. Arnold, if you can unmute yourself, and Ron will spotlight you. Jenny is the Chief Executive Officer for the Washington State Pharmacy Association. Uh, she spends half of her time on Zoom meetings like this. So thank you for finding the time to do that. And I think you spend the second half of your time with a family, maintaining that. The
Oh,
third,
that half of the life. Yeah, there is that.
and then there's a third half of your life where you actually prepare for those Zoom meetings. And then a fourth half of your life where you've done all these other programs or efforts to support the pharmacy community and the healthcare community in our state. You've worked with health systems and independent pharmacies and trying to bring them into the full provision of healthcare. So thanks for your work and advisory committees and the fourth and fifth half of your lives. I think we're already up to 120 hours a week of your time. But thank you for joining us tonight.
Oh, thank you for that nice introduction. I'm glad to be here and already see a lot of familiar faces I'm looking forward to chatting with tonight.
And the second person I'd like to spotlight is Trevor Douglas. Dr. Douglas is a chiropractor who's really spent more of his time, in his public health role with the Oregon Health Authority. He is the director of their prescription drug program and pharmacy purchasing at the Health Authority in Oregon, and works closely with the Medicaid program and the collaborative relationships with Washington. And he is really one of the go-to people in our that started in the Northwest, but has spread across the country with a pharmacy benefit manager type approach to lowering prescription drug prices with a group called Array RX. So Trevor will join us discussing that. Pharmacy benefit managers do bring up problems, but there are good things that we'll talk about tonight. Another, and the fourth member of this discussion is Ryan Pistoresi. Dr. Pistoresi is with the Washington State Healthcare Authority, the Assistant Chief Pharmacy Officer, and he's been involved with Medicaid, just like Trevor has in Oregon, and as well as a number of other efforts to control prescription drug prices in our state, especially, and we'll ask you some specific questions about that during this discussion, Ryan, especially with the total cost of insulin work group. Both Donna Sullivan and Ryan have been invaluable in making that group work. And now they are both being very supportive of our prescription drug affordability board in Washington that has just started. So we have created a group of questions that we thought we would start asking and help define what what pharmacy benefit managers really are and what some of the barriers are in this that they provide for or that they create, as well as some of the benefits that they provide. So let's start with just explaining to our participants, our membership, what a pharmacy benefit manager is.
I,
Jenny, do you want to start?
well, Ryan contracts and works with them really intimately, and Trevor as well. I'll take a bash maybe and let you all chime in. Pharmacy benefit managers evolved into a space that really had a need. There was a growing movement to start paying for prescription medications in the late 70s into the 80s. And to be able to contract with pharmacies, it's still in some states over half their pharmacies are independent pharmacies, to be able to contract and have agreements with them and process claims, also to drive generic utilization. You know, in the 80s, that wasn't the generic medications weren't kind of the understood just go-to that they are today. And so they were trying to control cost, drive generic utilization, create formularies. You know, really came from a very important place in healthcare as a third-party administrator. So kind of a middleman, a contract entity between the insurance companies and the pharmacies. And they still remain that today, ensuring that there's appropriate utilization of medications, and, you know, that you've tried something that maybe is lower cost before you go up to the more expensive medication, for instance. And so, you know, they play an important role in that regard. There's other aspects that they have gotten into, and you know, contracting also, and negotiating prices with drug companies, and, you know, creating some spread in the middle for them to profit off of. And so they've you know, created some opportunity for regulation as well. But, you know, they really start from an important contracting entity standpoint.
That's a great overview. Thanks. Thank you. Trevor, Ryan, do you want to add anything about what the potential is for our pharmacy benefit managers? They can do good, as well as creating some barriers that you know, even small community pharmacies are facing, as well as patients in every pharmacy in the state.
Yeah, no, I think that was a great summary of the PBMs by Jenny. The only thing that I would really add to that are that, PBMs do interact with virtually every type of person in the pharmacy supply chain. So they do have connections with the health plan, they have connections with drug manufacturers, they have connections with rebate aggregators, they have connections with pharmacy, they have connections with patients. So they do really have a lot of influence and impact on the access and affordability of medications. And I think what we've seen, since PBMs really became a business and an industry in the late 80s, is that there has been a lot of growth in this area, because there is a lot of complexity around prescription drugs. If you think about where prescription drugs were in the 80s or early 90s, we didn't have all of these specialty drugs or all of these drug classes that we do today. And so there is a lot of complexity that needs additional management. They have these contracts with these different manufacturers, with these different pharmacies. You have specialty pharmacies, mail order pharmacies. And so there has just been a lot of growth in this area. And I think that's really where a lot of the focus has been on PBMs is, how do we look at regulating the industry so that it does continue to provide a benefit to Washingtonians.
I might just add, I think Ryan and Jenny have done a great job. I'll just add that, largely there are three main PBM players that control probably over 80% of the market share of this business. And that creates some issues in the marketplace.
A monopoly.
Yeah. So I'll just leave it at that. I think you did a great job, Jenny, and thank you, Ryan, for filling in.
What about me? What am I? Chop liver?
Ronnie, you're asking the questions. We're just responding.
So there are some ways that pharmacy benefit managers can create problems. I think, Jenny, you mentioned some of those issues. Can we maybe explain to everyone what spread pricing is? One of the problems?
Yeah, well, one of the challenges or opportunities for more transparency, I'll say, is in spread pricing. And that's when what the PBM pays the pharmacy is not necessarily what they charge the employer or the insurance carrier for that medication. And in lies a gap. And, there's a lot of advocacy around, should there be an administration fee that's just kind of, you've done this work, you've controlled these costs. and so an administrative fee might be a way to control that spread. There's also rebates in there that are what the pharmacy benefit manager negotiates with the drug companies to get their medications on formulary. And similar, we'll talk when it comes to kind of those monopolies. When a pharmacy is thinking about saying no to a pharmacy benefit manager contract, they can potentially lose 30 to 40% of their patients, sometimes even more in small communities where an employer, a large employer in the town has that PBM for their employees. Similarly, drug companies, if they're looking at a take it or leave it, they can't get access to that many patient lives for their medication, then they've worked so hard to bring a drug to market and it's not getting that access that they were hoping to. And so there's when you get that big, it starts to create issues with contracting and fair contracting processes. They also now have gotten to be what's called vertically integrated. There was a great article in The Economist on October 8th that dubbed the term big health. And I think that's really honestly what we're talking about in many regards here, in that they now own these companies that start as pharmacy benefit managers or even healthcare companies now are co-owned by the same unit. So the same company owns the health insurance company, the pharmacy benefit manager, the clinic where many of the providers work, as well as the specialty pharmacy that they require their patients to use, which is the highest cost area of medications nowadays, as well as their own community pharmacies and then mail order pharmacies that they all steer and have favorable contract terms. And so you start looking at these behemoths in healthcare. And so it's not even just the pharmacy benefit manager, but it's these layering. And we have medical loss ratio laws that set how much a health insurance company can profit off of their covered lives according to the Affordable Care Act. Well, it doesn't really, it's those regulations aren't savvy enough to look at all those other layers of the business where they may be overpaying to steer profits from where they're regulated to where they're not. And I mean, I could go on and on and on about putting medications on formularies that cost patients more money, which is actually probably more what your group here wants to hear, is that there's no real regulations preventing pharmacy benefit managers from putting more expensive medications that they maybe get a larger rebate on. It may not be the best medication for their patients, but it might be good enough and they get more profit that way. Some of those rebates do go back to employees or plan sponsors, but clearly not all of them. And sometimes the way these are structured, they can cost patients brand name copays, even when a generic medication is available. And we see this especially with insulin until recently, until I think some new regulations coming in 2024 that may be impacting this. We have just continued to see insulin go up and up. And even though there are generics available on the market, those are almost never put on the formularies for the pharmacy benefit managers. Now I'll stop and let Trevor and Ryan chime in here because we can all probably keep going on this topic.
Yeah, I think Trevor was really alluding to when you mentioned that there's 3 benefit managers, pharmacy benefit managers that control, like, is it 80 or even more, 80% of the whole market, and they are owned by insurance companies. Is that accurate, Trevor, or is that your
there's vertical integration, as Jenny suggested, across the space. For example, United and OptumRx are affiliated and owned under the same group, if you will. And then if you just did a little bit of looking around, you would soon find out that United Healthcare has its tentacles throughout the supply chain and the healthcare delivery system, as Jenny alluded to and described. Man, where do we start? I mean, I think one of the solutions that Jenny alluded to around how PBMs get paid or derive profit was this potential of a solution, which is driving to a fixed fee type arrangement with a PBM. And I think that is worth exploring, because I think oftentimes PBMs market themselves to insurers and other payers as, we're not going to charge you an administrative fee. We'll manage your pharmacy benefit. And then the payer's like, oh, that's a great deal. There's no real administrative fee, but what is happening, and what has happened historically until more recently, when people have been made more aware of what the strategy was of these folks. I have to choose my words wisely. Is that they were engaging in spread pricing, and the true administrative cost was, to put it bluntly, obscene. It was way higher than it should be, or not commensurate with the service that was actually being provided for these payers and for these insurers. And I think there is a movement to ban spread pricing that's widely known, and you can read about it in various places on the web and news outlets. But I think also rebates are probably an even bigger source of revenue for PBMs. I think there's maybe $10 million in spread pricing, but hundreds of millions of dollars in the rebate space. And what Jenny was talking about just now about patients, being forced in a way to take on these brand drugs, that there are generic options available, is abhorrent, but there's a reason behind it. And it's because that PBM probably has a rebate agreement with that manufacturer to position that product as the preferred agent.
And those agreements, at one point, there was even a limitation where pharmacists could not tell a patient that if you don't use your health insurance and pay this copayment, you actually can get the medication for a lower price. But there are contracts that hospitals and institutions and individual pharmacies sign with these pharmacy benefit managers. So there are several issues that, and there's some great legislation, both nationally and in each of our states, that are looking at those issues. But there are some great examples as well. I was wondering if we could take a minute for Trevor and Ryan to talk about Array RX, which is a program that started in the Northwest and has actually started to spread, that is a transparent form of doing this. And actually, Ryan was very closely involved with our total cost of insulin work group, which came up with recommendations to use Array RX, as well as some new legislation that Senator Kaiser has put forward this year. So can we talk a little bit about Array RX? Trevor, you are the leader.
I'm happy to talk about it. Do we have an hour? Or I'm kidding. I think it's just really important to highlight that Washington and Oregon have over a 20-year history of working in this space. Very early on, leaders in our respective states recognized that the cost of pharmaceuticals at that time was getting out of hand. And I think just the course of time and the industry continuing to increase pricing and continually put consumers in a position of not being able to afford medications, particularly seniors and those that are uninsured or underinsured, really kept the spotlight and kept us, Oregon and Washington, working to try to find solutions that really better understood what the pharmacy supply chain presented, and the struggles, and how did we want to navigate that and who did we want to partner with in order to best leverage our purchasing power across both states. And that back in 2003 and 4, there was legislation introduced in respective states, first Oregon, then in Washington, to create prescription drug programs. And that was just prior to Part D. And it really focused on helping senior citizens afford medications and uninsured folks afford medication. But serendipitously, there was a meeting of the two directors somewhere in Vancouver, Washington. And there was a recognition very quickly that both states were doing the very same thing. And they forged an interstate agreement. So there was an intergovernmental agreement that established what's called the Northwest Prescription Drug Consortium. And that consortium served the Northwest until 2022, when we rebranded, and under a competitive procurement in 2019, run out of the state of Oregon in cooperation with the state of Washington, we created an offering that was able to be extended across the nation. And what it strives to do is bring transparency to the PBM arrangement for any public sector entity that pays for medications. And transparency is so overused and overutilized nowadays when it comes to the pharmacy space. And what do we mean by that? I think it's really important to recognize that there are 10 people that are public servants that are obligated by our appointment on a steering committee that oversee the work of ArrayRx and where we offer whatever program we offer, wherever we offer it. And so we require complete transparency on what is paid at the pharmacy as what is paid by the payer that chooses to work with us. So there is no spread, and we audit that, and we check that, and we make sure that that doesn't happen. We also require that every penny of rebate is passed through to the payer. We do this all with, as Jenny alluded to, a fixed, known administrative fee. And so it's known to the payer, it's known to the public sector entity that, this is how much it is, and everything that is paid at the pharmacy is what you're going to get paid. There's no games, and there's no withholding on the rebate. You get 100% of what is paid to us. We already paid for them to do that for us with that administrative fee that we pay. So we've had tremendous success. We've saved a number of entities within Washington and Oregon a great deal of money, and are really looking forward to welcoming other states and public sector entities as well. And we've extended the discount card program, which was the backbone of the Northwest Prescription Drug Consortium in Nevada and Connecticut. In 22 was Nevada, and this year was Connecticut. And we're looking to grow on that front as well, and are in discussions with several other states at the moment. So any questions I'm happy to entertain.
So thanks, Trevor. So do answer or put any questions you have in the chat. And let's turn to Ryan for a second to talk about the role that ArrayRx had in the total cost of insulin work group and the decision that came out of that. And Ryan, you also might point us in the direction for current legislation that came out of that group. And then we'll go back to you, Jenny, and hope you can talk about the status of the current legislation around pharmacy benefit managers. But Ryan, let's turn to you next.
Sure. So as some of you may be aware, we did finish up the total cost of insulin work group earlier this year. So this was a bill that passed in the state of Washington that directed healthcare authority to convene a work group consisting of various stakeholders in and around the pharmacy industry and pharmacy supply chain, and patients and providers to get together and talk about some of the biggest issues facing access to insulin in Washington state. As part of those recommendations, and this is in a legislative report that is published on our website, we looked at both short-term and long-term solutions around insulin affordability. And the one that Ronnie is alluding to is one of the short-term recommendations that we had around the emergency supplies of insulin. So this recommendation is modeled after legislation that passed in Minnesota, where they do have a program in place where the patients who have qualifying residency in the state, that they have a valid prescription, and that they are not covered by a health insurance that is paying for their insulin, that they can go to a pharmacy, sign up on a form, they check their eligibility, and they can get a 30-day supply with a maximum cost share of maybe up to $10. The cost of that then is borne on the drug manufacturer. And so the idea is that if these drug manufacturers are raising the cost of insulin so high that people have access to, as Jenny had mentioned earlier in this meeting, that they should then be the ones that, have to pay for it when there is this emergency situation and the patient is about to run out and they can't necessarily afford it. So as Ronnie had mentioned, we were looking at ArrayRx as the program that would administer it because they already have all of these different connections. And I think the common theme that you will be hearing in this meeting is transparency, right? I think really the root of a lot of these issues is that there is a lack of transparency. We don't know those dollars and those dollar amounts that are going between all of these different entities and what the incentives are. Because we have this ArrayRx contract that is transparent and that is administered by the state employees, that we do know all of the ins and outs of these contracts, and we can tailor the program so that it does meet the needs of our citizens and meets the needs of our state legislature. And so I think with the pre-filed Senate Bill 5776, which Ronnie had mentioned, it does actually begin the first step in creating this emergency insulin program. And if the bill passes this year and we do get the funding to implement it, then we could look at using ArrayRx to administer this program. I'd also mention that there is a long-term solution. And I think, that also, again, is, through ArrayRx. We would be looking at ways of purchasing insulin at a discount and looking at seeing if we could get rebates that could then be passed on to the patients. So as Trevor had mentioned, the contract right now passes on 100% of rebates to the payers. Well, what if we were to do that, to the patients? And we would have to get authorization to do that, but we could look at doing something similar to Utah, where they are using their public employees program to purchase insulin at a lower cost and provide those discounts to all residents of Utah. So those are two of the examples. And again, I'd mentioned that these are in a legislative report, so I don't need to go over all of it now, but that's open to reading.
Yeah, so thanks, Ryan. So let's jump into this pharmacy benefit manager bill, which is really one of the key issues and focuses for tonight's meeting. Jenny, do you want to do that? Should we pull in Senator Kuderer, or you can ask her questions? How about that?
I think it's very appropriate to pull in our bill sponsor on this bill. She's been a great champion, but I also don't want to put her on the spot because I don't know that she was preparing to speak to this bill tonight. But honestly, the bill that we're working towards right now, we're still before session started, and I know there's a lot of discussion around the bill, but I can definitely speak to the bill as it left the legislature last year and kind of what we are trying to accomplish for the health benefit manager bill. I think that the biggest thing to recognize is that we have taken language that already exists in Washington state law under the health benefit manager bill, lifted that language that's already been negotiated and put it in a standalone chapter that gives the Office of the Insurance Commissioner direct authority over the PBMs. And that mirrors regulations that have happened in many other states. And it'll cross over multiple different areas of healthcare, not just right now. The being in the health benefit manager bill limits that law's impact to just the commercial fully insured plans in Washington that are regulated by the Office of the Insurance Commissioner. It follows on the tails of the Rutledge Supreme Court decision and gives the Office of the Insurance Commissioner authority over all the pharmacy benefit managers that operate in our state. So it's already, most of it is vetted language, and it gives that direct oversight. And why that is really key is because the Office of the Insurance Commissioner, the OIC, has had a challenge enforcing the existing health benefit manager bill because the pharmacy benefit managers, some of their contracts include the commercial plans as well as ERISA and union plans or Medicare plans. And so they will hide behind that and say, oh, well, that's not all we do, so that doesn't apply to us. And we want, and as well as it right now, the way it's written is the Office of the Insurance Commissioner can only regulate carriers. And so they don't have that direct authority to slap the hand of the pharmacy benefit manager that isn't following the letter of the law. And so this would pull it out from commercial insurance carriers and them as a contracted entity and give them that direct authority. The other part of it is Section 6, and I got to say, this is really Senator Kuderer's baby on this topic, because a lot of it relates to mail order and giving patients the choice whether they want to have medications mailed or not. Some of my medications come mailed. I'm not anti-mail order, but you should have a choice, and you should have a right that if your medications don't come, if you do have questions about medications, you should have to do what every other licensed pharmacy in the country has to do. You should get counseling on it and have a pharmacist to talk to. Other rights as a patient with regard to mail order pharmacy. And it also does limit spread pricing as well in that section. So I see the senator's joined us. Thank you. Nice to see your face.
So you too. Hi, Ronnie.
So do you have a specific ask of us? Like, what can we do to support your bill and Jenny? What can we as members of the community, as healthcare advocates, do to help make this happen? Or Senator Kuderer, is there something more to add first to what Jenny was saying?
No, she covered the bill really well. This has been a work in progress for many, many years. I want to just point that out. It has evolved over several years to the point where we did feel it needed to be in its own separate statute in order to provide the appropriate regulatory function that needs to happen here in oversight. So that's going to be a sticking point, I think, coming up in this next session. And so and this isn't going to be a surprise to you, Ronnie, or any of the people on this call, but call your legislators, email your legislators, let them know it's Senate Bill 5213. Tell them that you support the bill and why. I mean, what we hear, and Jenny was at the last stakeholder meeting where we had, I think it was roughly 40 stakeholders there, it was a hybrid meeting, and they all got time to talk about what they liked about the bill or didn't like the bill. But what I asked for was I wanted solutions if they didn't like something about the bill. I didn't get a lot of those because I think we're kind of at the point where the bill is pretty well baked. But I will say that what we heard from the PBM representatives over and over again is that this bill will be a quote unquote cost driver. And I've asked them for what costs will be driven up because of this. But really what this is it's not so much a cost driver as it is a profit reducer. That's really what it is. And that's really what they're fighting for. And quite frankly, raising premiums to cover someone's profit margin is not a valid reason to increase premiums. So that's, I know there are some of us on this call who are very interested in the insurance commissioner position. And I can tell you that office needs to have a way to enforce the laws that we have passed in the state relating to PBMs. And this one is giving it the most teeth. So, I could use your support, and, Ryan and Trevor, I don't know what your pull is in terms of, the healthcare committee here in Washington State, but it'd be lovely to have you, support what we're trying to do here as well. So that's it in a nutshell. And no, I wasn't prepared to speak to that. So
thanks for letting us pull you in. The last time we pulled you in, you were Zoom bombed, and you really responded to that well. So thank you for jumping in
really
tonight.
quickly.
Of course. Thank you, everyone.
Really quickly, Senator, just so you know, I have been invited to speak in healthcare committees in other states. So my email can be shared and
call me.
And please don't be shy if you want someone to come and speak. I'm happy to. And it might be easier for someone like me to speak than someone like Ryan or Donna. Just going to say that. So I'm just going to ask Ryan and Donna to come and speak in my state when I can't say what I want to say.
So what we're going to do is we're going to unspotlight you all for a few minutes. But what we'll do is Cello, one of our board members, and is volunteered to gather together the questions. So we'll bring you back after a couple of minutes. And if you could spotlight another board member, Peter Lucas, who will share a brief fundraising pitch, so to say, with us. So Dr. Lucas. Who's in a different time zone and a different.
I'm trying to. There we go. Can y'all hear and see me? I guess so. So unlike opaque and for-profit entities that too often compromise healthcare, such as PBMs, we've heard about them tonight. We at Healthcare for All are transparent and nonprofit, and we are working diligently to improve healthcare and to lower costs in our state. And over the years, we've chalked up many legislative victories in Olympia, including helping to establish and appoint members to the Universal Healthcare Commission. And we're hoping this group could craft a publicly financed universal system based on our bill, the Washington Health Security Trust. We were very active in the previous session, this year's session, and many of the progressive bills that we supported and lobbied for were passed. So for an update on our accomplishments, this last session and before, click on the legislation tab on our website. Now, in order to maintain our momentum, here's the pitch. It is vitally important that we meet with our legislators, grow our membership, educate the public, and mobilize our supporters to spread the word about universal health care to their families, friends, and most importantly, those in power in Washington. And we can achieve those goals through the hard work of our lobbyists and communications specialists, social media, monthly webinars, such as tonight's excellent presentation, meetings with civic groups, and by hosting other events. Financial support of our staff, as well as our other activities and obligations, all require funds, which is why we're asking you to donate tonight and every time we do one of these webinars. And our goal tonight is $500 since we have so many people signed on. So please go to the links that I've been putting in the chat or to our website and click on the donate button. You can make a one-time donation, but we would especially appreciate it if you could make monthly recurring donations to support us throughout the year. So please donate so we can spread the word and bring about universal, publicly financed healthcare in Washington. And thank you, everybody.
Well, thank you, Peter. Cello Echeverria is going to jump in now. She's been looking in the chat, and we are have been adding the website that Peter was talking about to the chat. So add your questions, click on that link that Cello has been entering, and if we could bring everybody back in, let's highlight Cello Echeverria, who will be asking those questions, and Dr. Arnold and Dr. Douglas and Dr. Pistoresi. So come on back, everybody.
So, because of my setup, first of all, okay, so it got figured out. Good. Well, the Array RX certainly has generated a lot of questions in the chat, and I guess I would like to start with that because it is such an interesting and innovative program. Charlie Swanson asked 2 questions. Can Array RX grow into a more widely used and useful public PBM? So far, only, I believe, 5 states are members. And secondly, also to do with AARX, but more with Medicaid, does any Oregon CCO or Washington Medicare MCO use Array RX?
Want me to take that, Ryan? All right. So, Charlie, thank you for your questions, and good to see you on this call tonight. ArrayRx is in 4 states, actually: Connecticut, Nevada, Oregon, and Washington. And Oregon and Washington are the originating states. And we, as I intimated in 2019, purposely created a request for proposals that included the ability to leverage any other public entity in the country as part of groups eligible to be served by ArrayRx, by our programs. And we fully expect and are equipped to support any public sector entity wishing to have our services run in the manner that I described, and overseen by, currently there are 10 members from all 4 of those states that I mentioned, overseeing this, all of whom have extensive aggregated experience in the pharmacy supply chain space, in particular, pharmacy benefit management and pharmacy benefit administrative responsibilities in their various states. So there's your answer. And we're working with a number of other states. I don't feel comfortable disclosing who all those states are right now, but we certainly are in open dialogue with multiple states.
I know I've heard from other state pharmacy association execs asking about it as their state is exploring it. So I can.
Yeah.
I also don't know which states, but I know multiple have cropped up with that question.
Yeah.
And so
I have a visionary question about, we're thinking single payer, we're thinking foundational, laying the foundation for a single payer universal health care. Can we envision Array RX coming into coalition, for example, with California, who's going to start producing their own insulin?
Well, I think that
model.
Yeah, I think that's a question for California. Really, are they wanting to, actually help another state and the rest of the country? Frankly, what are they? They're in one of the top 20 economies of the world just by themselves, right? So, when you start including California into the conversation, it makes things a little bit hard. Not a bad idea though, and I would be interested in having the conversation and working with them. I think to answer your question more broadly, though, and Jenny alluded to this, and it's just really hard to get the momentum that we need, but there is an awareness now that ArrayRx has the ability to provide these services. And once we start rolling out in a couple of other states besides Oregon and Washington, then I think that that will grow the awareness of this program. And then you'll have, discussions like Ryan was having just a moment ago with the insulin work group, and developing programs to put on top of what ArrayRx already has in place in many other states and jurisdictions.
Well, and there are many different discount cards out there, I would highlight. And this one's one that really takes, I would say, into consideration making sure there's fair payment to the pharmacies to keep pharmacies open. At the same time, they're taking care of patients and leveraging the contracted rates that the healthcare authority has negotiated so that patients benefit from kind of that rebate and doesn't have to pay that and get dinged for that, if you will. And I think that that's really noteworthy, where all the other discount cards out there, I think, are for profit. They're taking in some of that spread. They certainly, I'm not hearing anything good about them passing through the pharmacy counter in terms of leaving pharmacies whole and keeping pharmacies open in communities.
Totally echo that, Jenny. Go ahead, Ryan.
I was just going to say, I'm sorry,
right? I was just going to say, so our agency, Healthcare Authority, we have had conversations with California about their insulin. And so that is a little bit outside of the ArrayRx purchasing, consortium. That has just been more for our health plans and for Medicaid. So just highlighting that, yes, we have had conversations with California about their insulin manufacturing.
And Chella, let me add one final comment about that, which is that the Democracy Collaborative has published a state toolkit on public manufacturing that we shared at our annual conference a couple of months ago, so that we can make that available on our website. So there is a plan, or there is a way to do this. It will take some work, but there are some real options available. Thanks, Cello. Let me hand it back to you. And you can still add questions to the chat. You can still find that link for making a donation. But we have about 5 or 6 more minutes. Cello, do you want to keep going?
Yes. So Charlie rightly pointed out that we didn't address the second part of his question, which is Medicaid MCOs in Oregon, Washington, Nevada, and Connecticut use
Really easy.
Yeah.
There's one coordinated care organization in the state of Oregon that uses our services. Interestingly enough, that was highlighted and pointed out in a recent hearing in our state that covered our state Secretary of State's audit of the PBMs serving the managed Medicaid entities we call CCOs in Oregon.
And for Washington, unfortunately, ArrayRx does not serve any of the MCOs. For a lot of the MCOs, they own the PBMs. So the parent company that is the carrier already has their own PBM. So it would be difficult if ArrayRx were to serve in the capacity under an MCO. So right now, it's just the Uniform Medical Plan in Washington that is the main one served.
And while this is a great tool, especially for those who are uninsured and underinsured, I don't want it to have that people who have insurance should be able to use their insurance at the pharmacy counter and get a fair price. And one of the pieces that our pharmacy benefit manager bill prohibits is charging a patient more than what they pay the pharmacy for medication. And that goes into this issue. And we do have the anti-gag clause, but sometimes if then prescriptions get run not on a pharmacy benefit manager's plan, then they interpret that as the patient not taking the medication, being adherent. And so then quality measures get dinged for both a prescriber, so your physician, as well as the pharmacy, especially for many of the medications like blood pressure medications and cholesterol medications, where this happens to, and Medicare 5-star ratings and all of that, there's downstream consequences. And so they almost force the systems into not offering a cash pay option because it just mucks with so many things. And so, the ArrayRx card is important, but if you have insurance, you should be able to use it and benefit from it. And they should be controlling patients' out-of-pocket costs for them and appropriately structuring things so patients can take their medications.
Thank you, thank you, thank you. So, Cello, do you have one more quick question, or?
I don't know how quick it is, but I think it's an important question. And it's from Lenny Sarkin. How do PBMs relate to Medicare Part D, to Medicare Advantage plans like Kaiser and United Healthcare, Aetna, et cetera?
So they are Medicare Part D, basically. They are the ones offering those plans directly to patients and managing those plans. I would say Medicare has a little more authority when it comes to some of the structure and requirements with them, but we've seen major abuses go on in that space as well, especially the overcharging for generic medications and low costs. Our pharmacies have been reporting that. And that there's a major issue, and there's federal reform, because those are difficult. There is some, under Rutledge decision, there is some authority that the state may have to be able to regulate how pharmacy benefit managers contract with pharmacies. But in terms of plan design and structure, that really falls under federal legislation. So we're looking at about 4 bills in the Senate. One of the major bills just got passed through the House last year, or yesterday, and goes, or 2 days ago, and goes over to the Senate. We're starting to see some federal pieces, both for Medicare Part D and pharmacy benefit managers in general, work their way through. And then their contracted entities under the PPO plans are part of the capitated model in Kaiser's example.
And I think what you're pointing out is that these Medicare Advantage plans are not true Medicare. They're insurance companies. Part D is the drug plans for Medicare recipients are run from private insurance companies. So that's what we're dealing with here.
Yeah, and Lenny highlights just Kaiser being generally a good actor in this space, keeping costs low for low-cost medications. And I, unfortunately, have seen some of the others that are not structured as they should.
So it's 2 minutes to 8. Out of respect for you, each of you, and for our speakers, we're going to wrap up. I want to thank Dr. Pistoresi, Dr. Douglas, and Dr. Arnold, and Senator Kuderer, who for letting us pull her into this discussion today. I want to thank the volunteers behind the scenes and encourage you to join us as a volunteer. So thanks, Ron Lovell, to Cello Echevarria, Rich Legoo, who did the admitting, D.W. Clark, who has been taping or recording this so that we can publish it on our website as soon as we put those pieces together. But most of all, I want to thank each of you for joining us tonight. It makes it worthwhile for us to volunteer. I think it makes worthwhile for the legislators to hear your reactions. And I think it makes it worthwhile to each of our speakers to know you're really showing a lot of respect for them just by showing up here tonight. So thank you, thank you. Thank you.
And it's so huge when we get patients and the voice of patients coming and speaking on these topics to the legislature. It's not just me on behalf of pharmacies, but the patients they really impact and showing that patient side. So thank you guys for all of your support, for caring about this topic, for just your passion, signing in support of the bill when it goes in for a hearing. All of that matters. And I appreciate you all so much for that.
Thank you. And have a good evening.